size and location of fibroid are important. The large majority of them are very small and located in the area of uterus, such they will not have any impact of reproductive function. Again, repeat. Non have impact on reproductive function. It is tumor have no associated with hormone. It very important when we speak next, for example, about treatment. Hormonal treatment, known this. Epidemiology, you can see in your screen. Most common solid pelvic tumor in women, more common in non-white women. Myoma are present in 20-25% of reproductive age women, but for no reason myoma 3 till 9 times more frequent in black than white women. Ended by the fifth decade, as many as 50% of black women will have myoma. Yes, you see in the picture a lot of women will have myoma in the future, but this question again, what interesting in this question? So this question interesting. A lot of myoma will not have diagnostic, will not have symptoms in future. We will know this diagnosis only because we will see it after the woman will be dead. A lot of this will not have symptoms in future. The etiology of this common tumor is not known. The myomas are not detectable before puberty and being hormonally responsive normally grow during the reproductive year. Factors: estrogen, progesterone, growth hormone, increase of for heat traction of estradiol, increase aromatase. Так. This dysregulation of the number of growth factors of the myomatous uterus, many of the factors regulate a process angiogenesis. Vascular endothelial growth factors, hyperbinding epidermal growth factors, platinum-derived growth factors, transforming growth factors, parathyroid hormone-related protein, prolactin, fibroblast growth factor. Students, if you will have some questions, you can write questions, for example, in WhatsApp. 1 second, I will give you my number in WhatsApp. And if you will have some questions, you can ask me in WhatsApp. 1 second. Non-hormonal risk factors of uterine lemma, any history of hypertension, any history, no preeclampsia, hypertension in before pregnancy, hypertension diseases, gestational hypertension, all can be. Hypertension requires meditation, hypertension at the age least 35 years, hypertension of 5 or more years duration, pelvic inflammatory disease, chlamydia infection, intrauterine device, and perinatal use. Pathogenesis. Myomas contains estrogen receptors in higher concentration than in the surrounding myometrium, but in lower concentration than in endometrium. Data concerning progesterone receptors in myoma are inconsistent. Myoma generally increase in size with estrogen therapy and during pregnancy, but decrease in size and even disappear following menopause. The free generation localization of fibroids: subserosal, intramural, and submucosal. I need And you can see in the screen, 1 second, yes, in the screen about localization, all variant of localization myoma. Cervical, subserosa, pudendal vaginal localization, submucosal localization, intracavity localization, intramural localization, and pedunculatus subserosus. All variants of localization. Yes, you can see here, and you can see variant. The most interesting part for understanding. Myoma can be everything, everywhere. The only type then will be have any impact of reproduction function in the submucosous type that push it on the uterus cavity. They are much less common than the other two types of fibrosis because of their location inside the uterine cavity. Subserous fibrosis can cause infertility or miscarriage. I think it is have no questions. I hope you understand why intracavity and submucosal can be reason of miscarriage. What causes fibrosis? Not much is known about the causes of fibroids, but evidence suggests that they grow in related to estrogen and possibility of the hormones. In fact, increase levels of the hormones may speed up the growth rate of fibrosis. Obesity, increase estrogen. Um, do you remember, students, why obesity increase estrogen? I hope you remember obesity because this tissue, this tissue can produce estrogen. Multiparity, frequent medical abortion, genetic predisproportion, infection to chronic endometritis, family predisposition, and short menstrual cycle. Pathological findings. Myomas are usually multiple and vary in size and location, have been reported to 10 pounds to 45 kilograms. Of course, it may be, but it is not often situation. It is very, very, very 1 to 1,000, more than 1,000, 1 to 1 million. Gross pathology reveals tumors will characteristic were like tuberculated appearance as in pseudocaspular layer is present. No question. WhatsApp, no question. Chat. Okay. Pathological findings may ungender various types of degeneration. Hyaline degeneration, calcification, infection, necrosis, and saccharomatous change. Not often situation. You see, the first, the most common, next, second in popularity, third in popularity, and fourth in popularity. Hyaline degeneration, calcification, infection, necrosis, or saccharomatous changes. Pathology. Myoma are usually multiple, discrete, and spherical or irregular lobulated. Myomas have a false cause plus size. Have Elmont myomes have a false capsular covering. They are clearly detached from surrounding myometrium and can be easily clearly enucleated from the surrounding tissue. Yes, it is most common situation. Capsular covering and easy for deleting. But we have another variant. Risk factors for developing fibroids. Increased risk. Age. Middle-aged women are commonly diagnosed with fibroids. Nulliparity, obesity, previous previous fibroids in family history, and race, African race. Decreased risk tobacco abuse, prior childbirth, and oral contraceptive use. But you should remember, you should not use oral contraception without consultation with doctors, and you should not use oral contraceptive when smoking, for example. Submucosal complaints. Again, a lot of part of myoma have no symptoms. When we start a discussion with complaints, if a woman have symptoms, for example, is submucosal, it will be dysmenorrhea, severe pain. If it is subserosal, on without pain. If it is interstitial, pain in abdominal cavity. But subserosal, maybe without symptoms too, will be in start of common symptoms. Pressure. I think you understand why if in uterus have myoma, woman feel pressure. Abnormal uterine bleeding for menorrhagia, pain, and less common symptoms. It is infertility and it is pregnancy complication, miscarriage, preterm labor, fetal malpresentation, labor complication, and spontaneous abortion. But you should remember, this myoma may have a little chance to be reason infertility, but intracavity malaria have a lot of chance to be reason of infertility. Signs and symptoms. Majority are symptomatics and are only suspect from pelvic examination. Yes. Most common symptoms is abnormal uterine bleeding, hypermenorrhea, most common secondary anemia with associated symptoms may be result. Pressure on bladder may result in suprapubic discomfort, urinary frequency, pressure on the rectus sigmoid may result in low back pain. We speak about it. Majority asymptomatics. Edema and varicocysts of lower extremis may result from large tumors. Pain may result from twisted pedunculated myomas or degenerated hemorrhage or increased myomas. Infertility may result from submucosal myomas or with distortion of uterine cavity. Rapid growth, particularly in perimenopausal or postmenopausal, may indicate sarcoma. But it is not often situation. It may be, but it is not often situation. I think you understand this. Abdominal exam, uterus palpably above symphysis pubis, bimanual examination, enlarged mobile and irregular uterine contour. But if we speak about non-intracavity, intracavity we cannot fill in by manual examination. But yes, if intracavity very big, we can. But the most often situation we cannot. Differential diagnosis. Of course, pregnancy. Of course, if we speak about gynecological pathology, we try some different diagnostic with pregnancy. What different diagnostic? Negative pregnancy test. If we speak about and of course ultrasound. A lot of part of the first in pregnancy have no negative pregnancy test, and maybe women have no problem with menstruation. Ovarian carcinoma, ovarian tumors have differentiation in bimanual examination. Sigmoid tumors or sessile tumors, tubo-ovarial abscesses, appendiceal abscesses. A woman will not have symptoms inflammation. Differentiation in symptom inflammation. Adenomyoma, leiomyoma, hyperplasia of endometrium. Adenomyoma, leiomyoma, it is question not the diagnostic in beef. Adenomyoma, leiosarcoma, it is question of laboratory and instrumental diagnostics, and polyps too. And polyps is questions of colposcopy. Hyperplasia of endometrium, diverticles, pelvic kidney, and oracular cyst. This question, I think this question's most into better differential diagnostic with instrumental. Complications. In non-pregnant women, heavy bleeding and severe anemia, urinary of bowel obstruction from large of parasitic myomas, and malignant transformation. Myomas and pregnancy, infertility, increase in size and degeneration change, preterm labor, malpresentation, postpartum hemorrhage. Oh, sorry. The students, do you see picture now? Students?
Yes, sir.
Uh-huh. Laboratory pregnancy test for differential diagnostic and CBC and differential count. CA 125 may be signature elevated in some cases of uterine myomas, but generally is more useful in differentiation myoma from various of gynecologic adenocarcinomas. Yes, I am not tell about, but yes, it is the most common laboratory differential diagnostic, oncomarkers. Or the clinical investigation will be enough to establish to diagnostic. Hemoglobin concentration to rule of anemia, imaging of uterine tract to exclude heteroperitonesis, heteronephrosis, ultrasonography to distinguish ovarian mass, fractional D and C8 in ruling out cervical uterine carcinomas, hysteroscopy and needle biopsy may help diagnostic submucous myomas. Laparoscopy may be useful in complex cases and in ruling out as pelvic pathology, and laparotomy. Laparotomy may be diagnostic to continue to treatment laparotomy. Imaging ultrasonography show characteristic Yes, tell about ultrasonography. Yes, we can use CT scan, MRI, but the most often situation ultrasonic it will be enough. Intravenous piellogram and barium enema. Ultrasonography with contrast. Good idea. Maybe it will be better. I understand this picture not better in our life. Maybe some will be better. Yes. Some next will be better. Uterus. This is uterus. Oh, in reality, it will be seen better. Uterus and fibroids. Very big fibroid, yeah. Yeah. In this picture, you can see the real structure of myoma. General measures. Treatment must be individualized. Patients with minimal symptoms may be managed with iron preparation and analgesics. Conservative management, asymptomatic myoma less than 40 week size generation should be closely observed with pelvic examination and ultrasonography and 3 to 6 months intervals as long as site stables usually regresses after menopause and non-surgical therapy. Treatment must be individualized. About what we should think when we speak about this treatment? We should think about have woman children or have not. What if her age and what the size of what size of the tumors and what symptoms we woman have now and what about these tumors and chance of woman infertility of woman miscarriage. Lutein releasing hormone antagonists include an abrupt artificial menopause with cesarean or cessation of bleeding and shrinkage of myoma. Not recommended for more than 6 months. May be useful in premenopausal patients or as an adult in preparation for surgery. Progestins may reduce the amount of blood flow, they not reduce myomocytes. Myolysis by needle care. Myolysis and maybe cryotherapy. Learn them on common. Treatment conservative. Gonadotropin releasing antagonist. fibroid recur with medical stopped. Progesterone, mifepristone. Progesterone receptor binder, mifepristone. Less suggest and in private therapy. Danazol or prepared progestin, Depo-Provera. And of course surgical. Some indication for of the use of gonadotropin releasing agonist in women with uterine myoma are as follows. Preservation of fertility in women with large myomas before attempting conception or preoperative treatment before myomectomy. Treatment of anemia to allow recovery of normal hemoglobin levels before surgical management, minimizing the need of transfusion of allowing autologic blood domination. Treatment of women approaching menopause in an effort to avoid surgery. Related treatment of large myomas to make vaginal hysterectomy, hysteroscopy, resection of ablation of laparoscopic distraction more feasible, treatment of women with medical contraindication to surgery, treatment of women with personal of medical indication for delaying surgery, complications. Contraindications, really sorry, my mistake. Contraindications, progestin history of thrombophlebitis, of other thrombophlebitis in her anamnesis. All of this problem will be contraindication. LRH antagonist, history of osteoporosis. Lower dose mifepristone we can use. And surgical management. Surgical management in some situation. The big size of myoma, submucosal localization, symptoms, symptomatic, very symptomatic picture, and maybe infertility in the situation associated with inflammatory disease. I think if we put bottom and we'll see next picture, it will be about infertility. Infertility, surgical procedure, hysteroscopic of laparoscopic coated of laser myoma rejection can be performed in selected courses. Myomectomies may be performed in younger women descend to manual fertility. Hysterectomy, either vaginal or abdominal, is procedure of choice for